Good afternoon. My name is Deepak from the European Institute for Innovation Through Health Data. I'm delighted to be part of this Congress and to introduce to you here a panel discussion on health data, patients' perspectives on health data, on the sharing and use of health data. And I think the magic keyword really for this panel discussion is about trust. How can we make sure that patients feel a sense of trust about their data use? We are concerned that we want on the one side to make more and more use of health data, which is vital if we're going to accelerate research, new treatments, new devices, new algorithms, improve health systems, public policy, health system strategy. But at the same time, more and more people are aware of the importance of data protection, how their data is at risk on the internet, for example. Why they are concerned is reasonable. There are laws, data protection laws in Europe as a whole and in each country, making sure that the rights of citizens are protected. So we need somewhere along the line to find a middle ground, a sensible way of making good use of health data whilst at the same time upholding the protection of individuals, making sure that when health data are used, patients feel comfortable that their data is being used well, wisely, that their identity is protected, and that the benefits of that use are things that they would support. That is, that the data use is of benefit, maybe not to each individual, but at least to others in society who may have the same condition or a different condition. This is what we need to assure, but it's not an easy balance to find. And I'm delighted today to have panelists who will look from three perspectives: a patient perspective, very important one, a legal and policy perspective, but also bringing a flavor from Data Saves Lives into our discussion, and someone who actually builds research platforms that do data analysis and is part of a major European project that is trying to uphold the very best practices in data processing. So I'd like to now turn to my panelists and welcome them. And I look forward to their discussion. But then after this session, I'm going to be here and I'm going to be listening and looking out for your chat questions. Don't wait until you've heard them speak. As you think of things, please type in the chat so I can keep an eye out and start thinking of the answers ready to give as soon as we've all finished the panel discussion. I look forward to it. And please welcome my panelists. It'll be great to have this interesting discussion today about health data, issues around how we can make sure that everybody trusts its use and values its use. Let me first turn to Petra Wilson, who is one of our panelists today. Petra, would you mind just telling us a bit about yourself?
Deepak, thank you very much. It's a great pleasure to be here with you today. So I wear very many hats. I'm only going to mention two of them just now. One is that I'm an editorial board member of the Data Saves Lives group, which of course makes me think a lot about how we can use data and how we can build that trust and value that you mentioned. I also serve on the WHO Digital Health Technical Advisory Group, which allows me to think about these things at a global level, and particularly the value of data in low and middle income countries. By profession, I'm a public health lawyer, and I've been working in and around health data for over 20 years. And pleasure to be with you today.
Great. Thank you very much, Petra. And then Patrick, let's turn to you. Could you also say about yourself a little?
Hello to you and to Petra, and it's really nice to be here today with you. So I'm Patrick, I'm from Croatia, and I'm a person who is diagnosed with multiple sclerosis, but also I'm the president of the local community here in Zadar for MS, and I'm representing the young people on the European Multiple Sclerosis Platform as a member of the EXCOM, as the Executive Committee member on the EMSP. And it's for me a privilege to be today here because the topic is really important, and it's I see there are a lot of troubles in the trust between the data and the patient.
Thank you very much. And I think, Patrick, if you don't mind, I'd like to start by asking you a question, because trusting about use of data is all very well, but people have to first understand why we need to use health data. You know, there is data that people are very familiar with. If they go to a hospital or to a family doctor, they expect that professional will take some records and will type them into a computer these days. And they also know that information goes between a hospital and a family doctor if they need to see a specialist and so on. But when it comes to making more use of data, for example, for research, the public are often not that familiar with it. But do you get a feeling from the patients that you mix with, the MS patients, for example, do they understand why we want to use data? And what do you think is what makes them feel that data is important?
So that's a really interesting question and difficult question, because it's the people in most of the countries, they doesn't know about that anything, and they are just okay and familiar with the data, what you said, in the hospital, and they think that's the closed door and that information cannot go outside, and they're fine with that. When we are talking about a patient who wants to share the data even more, there are small numbers of that people, and that's a problem, because I and other people who wants to share the data, we think that when we share something, that can make forward steps in research for MS. And there is no medicine for MS, so that can help. But in most of the people, they are closed and they don't want to share the data. Also, that is connected, I would say, also with the culture in countries. And you have you have in Germany, or you have in Sweden, they are recording the data from the birth, from the first day of the child. And we here in Croatia, we don't have even the register for people with MS, and that's really a big problem. So it depends to the country, and I would say in the most of the country, the people are closed for that. It's only the relationship between the patient and the hospital, and I think that's a not good thing. It's not a good point of thinking about the data.
No, that's very interesting. Do you think that if there was more awareness of the value of research and how data is important for research, that patients that you mix with would accept that? Or do you think they would still be unhappy about that data use?
In my opinion, I think they will be more open, because they would know that it's a good thing, and I think the education here is really important.
Okay, that's very helpful. So Petra, can I turn to you? You're very familiar with the different stakeholders that use data, conduct research, and you know that there are both kind of public bodies like academic bodies and health insurers, healthcare payers that need data to understand how to optimize care, but also industry makes a lot of use of data and actually wants to make more use of data. Do you think that we need to do more to help the public to understand the diversity of actors who contribute usefully to research through data?
Absolutely. I think a lot of people, if they think about data being used for research, they will immediately think that it's for the development of a new product. So, of course, that is a really important part of it. And we have clinical trials, and we have using existing medical records to enhance the information that is found in clinical trials. I think we need to make sure that people understand the value that, for example, allowing your electronic health records to be used for clinical, for research is very important. I think where people are perhaps not nearly as aware is how important routine data in a health record is for health planning. And if there's one thing that COVID has taught us, is that we need to plan, we need to be prepared for the next pandemic, and we need to be able to really use data for planning, for using our health resources, whether that's human resources or medicine or PPE, whatever resource it is, in the best possible way. So I think that's really, I'm very sorry, my camera went off briefly there. I think it's really important for us to really show that breadth of purposes to which health data can be put, both scientific research and also some of that sort of planning, social research. Really important.
That is important. Now, when I've interacted with patients and patient groups and run focus groups and workshops, the one thing that people have said is that whilst they may be happy in principle that data from their own records is used, they really don't want their identity to be revealed to all sorts of other people that they don't know, and they don't know. I mean, they don't mind the data being used, but they really want to be confident. Now, firstly, with regard to things like policy, so I will put this to Petra first. Policy and law and instruments. Are there enough rules that should protect an individual's identity if their data are reused? Do you think we have the right legal and policy framework in place?
I think we have the right policy and legal framework, but the problem is it's a framework. It hasn't really got the whole meat on the bones yet to make it really operational. The GDPR, for example, the General Data Protection Regulation, does give us a very good framework, but it's still a little bit clunky. It's still too much simply the bare bones of the rules. And we will now, I think, really need to develop that with policy, with guidelines, with support to help doctors, patients, researchers, public authorities be able to make use of data whilst protecting the privacy of an individual. And protecting the privacy of an individual doesn't have to be totally at odds with reusing their data. So in short, we have a framework, but that's actually all it is, a framework.
So are you saying that a fair amount of detail and practical rules, but practical guidance is needed for how to find that balance that you implied between keeping the identity protected, but at the same time being able to use the data to conduct research?
And I won't take too much of the time, but I've been involved in a number of research projects. One that was done at the beginning of this year, 2021, where we interviewed healthcare providers and researchers across all 27 countries of the EU. And what was really striking was how often a researcher said, well, maybe the GDPR would allow me to do this, but it's too complicated, it's too frightening, we don't really know what the rules are. And the data protection officer within a hospital or with a health authority has also been saying, yes, probably the law would allow it, but we're just not certain. So in order to avoid any potential liability, getting it wrong in law, they err on the side of caution and say, okay, so we won't use the data, we won't do the research. And I think that's a big shame, because we're missing out on opportunities because we have a framework, but we don't really know how to implement it.
Right. Oh, very, very interesting. So, Patrick, I'd like to ask your opinion on this. I asked you earlier about the attitude to using data for research. I'd now like to ask you about data protection fears, because I said that patients I've spoken to have indicated an anxiety that their identity should be protected. Does that align with what you've picked up? Have you heard about people's anxieties about data, or do you think that they are concerned about data protection?
It depends by the people. Every person have their own opinion about that.
Yeah,
and
very
I understand. I understand that the people want to hide the names and the details about the patient, but sometimes that's really important, and it's hard to talk about that because everyone has their own opinion about that. But when I talk more and more with the young patients, with the patients here in Croatia, they are not close to share the information, even with the names, or maybe without the information about the patient, but they want to see more from the scientific side and the industry, they want to see more collaboration with the patients. So here in Croatia, that's something what's really close. And for example, the research and the clinical trials are also not something what is open here. And the patient want to see more collaboration, more partnership in that, because no one can better the disease than the people with this disease.
Okay, that's actually very important, and I hadn't predicted that, and that's actually really interesting for me to understand from you. Thank you for that. So really, it's about being involved. They want to feel that they are part of how their data is used, even if other people need to use it. They'd like to know about it. They'd like to hear about the results. They would like to feel engaged with that whole process. Is that right?
Yes, actually. And when the patient is in the center of some research, then it's really important for people, because, for example, the multiple sclerosis is not affecting only the body and only that you see that. It's sometimes it's not just sometimes, it's often the quality of life. So when I have some treatment what is doing good for my body, but the quality of the day is bad, then do we have a good treatment or are we having something bad? So the patient want to be more involved, and I think with that we can make more forward steps in the research and more educate. We can more educate people, and I think that will be good also for the patients, but also for the scientific side.
Right, that's very interesting. Now, one of the things that I've often heard from people is they would like to be asked for permission. In other words, you can use my data if you ask me first. And it sounds so simple. Just, if you want to use my data, ask me and I'll say yes or no. And the GDPR, our lovely data protection regulation, does have this provision for informed consent. And so it would sound like, in theory, the policy framework is there. I'm using Petra's word, framework. So, I'll turn to Petra first on this topic. So it sounds all very nice. We've got a beautiful framework and it refers to informed consent. People are saying, ask me, and then I'll say yes or no. And then there are people who are trying to build big data infrastructures who say, it's just not possible to do that. So you've engaged with those people. You understand about the people who say, just ask me, and you understand the people who say it's not practical. Can you explain a bit about why it's so hard? Because it sounds a bit easy. Yeah. Ask me and I'll say yes or no. It sounds so easy to say the sentence. The reality is very different. Can you tell us?
Yeah, so there's so many things that spring to mind here, but one of the things I would urge us to think about, how often do we click yes on a website when it says, do you consent to the cookies?
Every day.
None of us read the documents, even people like me who preach about this all the time, because in this situation, because we want to get to the information or we want to buy the service or whatever it is. So that's one thing that makes it practically impossible, not impossible, but difficult, because if we take the wording of the GDPR, which, as I said, is an interesting framework, but if we take that literally, we would have to ask every single time we want to use somebody's data for each specific use, we would have to have specific consent. And that would mean, for example, we may need to ask a patient 15 times in the course, I'm taking a number out of the air, in the course of a study. And we would get to what's often referred to as consent fatigue, which can have two effects. People either just say yes and then feel cheated because they don't really know what they're saying yes to, or they just say, you're asking me too often, and they just say no. I think there's another thing that we need to think about is the idea of consent and ask my permission is based on giving people really the possibility to understand what they're saying yes to. And one of the things that's very difficult in a healthcare situation, and Patrick, I'm sure you'll have something to say about this, is there's an imbalance of power. That you visit a physician because you want their knowledge and their skill and their help. So you're not in an equal situation. So if that person then asks you for your consent to something, how empowered are you really to say yes or no? So there's a whole issue there about the social situation. But there is, I think, a very interesting new concept that is being born, and it's a long gestation and birth, because since about 2013 there's been a movement to develop a concept of dynamic consent, of having a model of consent for using health data for research that is, as in your words, Patrick, really involves people from the beginning and allows people to turn on and off the consent to particular parts of research much more easily and be more involved, so that they may be cautious and say, yes, you can use this bit of my data, but not that bit at the beginning. And then when they get more confident with the research, they can offer more consent. There is actually a very interesting project that has really been pushing this forward. It's run out of Oxford University in the UK, and it is slowly really beginning to gain some traction. The problem is, and I'll come back to my first answer, it doesn't fit very well with the framework of the GDPR. And that's why I said we need some real detail on that framework, so that the idea of consent can be made properly workable for healthcare research.
So, Patrick, you can react if you like to what Petra said, but I'd also like you to think about what you think is realistic for patients. You said at the very beginning of this discussion that a lot of patients don't even really get a sense of what research uses data for, and there's a bigger need to improve awareness. Now we're looking at consent and asking people for permission, or the difficulty of asking people for permission because they've got to understand it, and it takes time, and it could be many, many times a day even that they get asked. If their data is flying around Europe, their data might be used 20 times a day. Consent fatigue is a phrase Petra described. Patrick, what are your reactions to all this? I'd like you to speak yourself as a person, just be you, but if you've encountered any other patients you mix with, share any thoughts as well.
Yes, thank you. So I would like first to reply with on Petra, and I totally agree with you, but I also fear the problem is in the disbalance in the Europe. So you have UK and you have the data, and you have the health system on a really high level, and then I know the patients are in the center. I was involved in many projects where made the research with the patient in the center, but for the other young people here in Croatia, that's anonymous, so they don't know anything about that. And because of the EMSP, where I'm part of the EMSP, I started to be more involved in research like that. And I can only be thankful for that, for EMSP to get me involved. But for the countries like Croatia, like Slovenia, like the eastern part of Europe, that is a gap. That's not something what is really in common. And I think that this balance is really a big problem. And for the research, for the sometimes I feel the same thing, that you just need to go to the patient and ask them, can we collect your data? And most of them, I think they will say yes, but they want some explanation. The problem is also, I think, with the explanation. So sometimes there are too many pages, too many descriptions. And as you said, when you accept cookies, I accept it because the description is too long. But I don't have a time in a 15 seconds to read the 50 words. So the education to improve that education, so that we communicated more about that. I think in that way we can also build something on a high level also involve the GDPR, because I know there is a problem. For example, it's a stupid problem, but here in Croatia, they said that some industry for, let's say, for telecommunications, they cannot connect because of the GDPR. And then you have every second day a phone call, they are offering something. And then we don't know, is the GDPR on a right way, or is not for everyone on the same. So I think with better educations, with the people, with the patients, and with the description, with a clear sentence, if you share data, you are offering this, and this, I think it can be better.
You've both raised some really interesting challenges about how we can find some balance between enabling data use but protecting privacy. Now, one of the exciting innovations in this area is a concept known as federated architectures. And before I turn to you both about this topic, I'd like to introduce an expert who I had the chance to interview a little earlier, called Kees van Bochhoven from the Hive, a company based in the Netherlands, who's part of a European project called Eden. He's an expert in federated architectures, and I spoke to him to tell us more about this so that we can then use that knowledge to inform our further thinking. So now over to Kees. So let's turn to Kees. Thank you very much for joining our panel. Kees, would you mind starting off by just telling us a little bit about yourself and the company?
Sure, Deepak, and thanks for having me. So my name is Kees van Bochhoven. I'm the founder of The Hive, which is a company located in Utrecht, and we help organizations to manage their biomedical data and to use all kinds of biomedical informatics, be that observational research, but also genomics, using wearable sensors, etc.
Fantastic. That's really good. Now, I know that one of the important flagship projects that you're involved in is the IMI project known as Eden. And I wonder if you'd mind just briefly mentioning what is Eden all about?
Right. So the Eden project is about building a data network in Europe in which we can do federated studies, meaning that we are bringing on board now already more than 100 different data partners. So a wide variety of what we call real-world health data sources. And the reason we have this network is in the second E in Eden. So Eden stands for European Health Data and Evidence Network. And our goal is to be able to generate medical evidence at scale in Europe and also on a global scale.
That sounds really important. Now, I know that we badly need to learn a lot more from data, and we need to do that in a way that allows us to look at many, many patient records, not just a small number. So this kind of European level sounds really important. Can you tell us what it means?
Absolutely, Deepak. So the security of data, the challenges and the risks, they just increase with the amount, right? So we see that with large companies that generate enormous amount of data and the risks involved with that. So in Eden, we have a different tactic. And instead of building a large collection where we put all the data together centrally, we use harmonization and standardization techniques where the data stays at the source. So the patient data doesn't leave the hospital or the GP practice or maybe the registry or the national data medical quality centers. We also have a number of national authorities that, of course, collect data on behalf of citizens, and they can also participate. But the data stays where it is. And thanks to the harmonization, where we make sure that the data is semantically and syntactically aligned, so that they use the same terms and terminologies, but also that they have the same structure. We are able to execute studies at scale.
Okay, so the kind of data that travels along the wire, if I could call it like that, I realize it's probably optical fiber these days, would be something like, how many patients do you have that have this disease with this severity on this treatment with this X-ray finding? And the answer coming back from one site might be, I've got 37. And what I'm sensing from you is I can ask that question to 100 different sites, and they'll all understand my question, check in their data in exactly the same way, and give me an answer that I can then pool that and say, well, actually 10 of the sites in Germany told me this, 16 in France told me that, and I can start to form a picture of these patients and where they are, but without knowing who anyone is. Is that right?
Absolutely. In fact, you've just described one of the main use cases or type of questions that we can ask the network, which is characterization.
Okay, so perhaps I was I was simplifying it too much.
No, I think that's a great start. So characterization is about understanding what happened to them, what happened to patients. These are in sort of epidemiological terms. You're then looking at incidence rates, indeed patient. You can stratify the population. So look at how is diabetes type 2? How does that stratify across the age ranges or sex, etc. The second use case that we can also do with the network is to look at causal effects. And examples would be the safety of or efficacy of drugs. Maybe one interesting example. Last year in March, when the coronavirus pandemic sort of really hit, we had a meeting planned with Eden, also with the international Odyssey community in Oxford, which we had to cancel the face-to-face aspect, but instead we made it a virtual meeting called the Studyathon. And in the Studyathon, not surprisingly, we decided to focus on COVID-19, which was a new disease at the time that we had so many questions. We had a whole list of questions. One of the questions was, there's this new drug that is being touted by many as an important medication against COVID, hydroxychloroquine, by the President of the United States, for instance.
I remember that occurring as a question. And the thing is, the newspapers were full of politicians and medics saying they think it works, they don't think it works, without really the evidence. That was a big gap, wasn't it? So how did you address that gap, that evidence gap?
Thanks to the standardization that was already there within Eden, but also in the global Odyssey community, so observational health, data science, and informatics, we had ready to go a number of hospitals, for instance, in New York, that had quite a few COVID cases and had the data already in that OMOP model. So we were able to look at what is the rate of suspected COVID or infections, confirmed infection, hospitalization with COVID, but even, for instance, hospitalization with influenza, because the early cases may not be labeled, and to compare between all these different groups. So we had 12 questions, medical research questions. One was, what is the safety of hydroxychloroquine? It's not even limited to COVID, but hydroxychloroquine is already a drug that was used a lot. It was just not very known what its safety profile was, sort of outside of the conditions that it's normally used in. So that's what we immediately were able to study in millions of patients across the world. And out of this came eventually also some peer-reviewed publications months later. But more importantly, we also showed that the preprints that we published, of course, not only from Odyssey, but also from other groups, had a direct effect on medication use in real world. And
so what you're telling me here is that you not only were able to perform at high speed, societally critical research, for which we really needed the answers. Secondly, you got it to the point of academic peer review, where people would say, yes, this is a scientifically sound study, and you changed clinical practice behavior.
That's right.
Fantastic. What an outcome. So now, please tell me this. Imagine if there are patients listening to this saying, well, it sounds rather clever. Why should I feel safer about my data protection, my identity in this kind of model?
Yeah, so I think there's two aspects to that. So one is that this principle that the data stays in the hospital makes it also the responsibility of the hospital, where in my view it belongs, because they have the direct clinical contacts of safeguarding that data. And of course, as Eden, we do not prescribe how to do that, but there are also laws for that, as we have discussed in this panel. The second aspect is more to do with the scientific transparency of how we go about, for instance, making estimations, making causal inference, to really claim that a drug is safe, or to even claim that a vaccine is safe. Very important studies and work being done right now in vaccine safety is we need to compare with historical rates of adverse events.
Yes, of course. Very important. Thank you very much. I'm certainly aware of more and more organizations and national infrastructures that are promoting this approach. So I think you really are on, I would say, the crest of a wave if you were in a minority situation, but you're on a massive wave that is really already a kind of tsunami of approaches to how to do things. It's great to hear from you. Now, I'd like to turn our discussion to one of the ways in which a lot of countries and European projects are starting to make big-scale research possible. It is through a concept known as federated architectures or distributed querying. And just to explain what it means that the person conducting research does not ask to have a copy of the data and store the data. They instead send a computerized query, for example, to say, I'm looking to find out how many patients you have in your hospital with this disease of this severity on this drug. And please, can you tell me out of those, some of the lab data, just the lab information, or maybe even just how many people have lab values greater than this level or that level. And all they get back is some numbers. And they get back some numbers that tell you how many patients there are, but you don't have any individual level details about those people. So you don't know their name or their address or even exactly what other diseases you have. You just know what you asked. How many people have this? And if you run that question computably across 50 or 100 or 200 hospitals across Europe, you can end up analyzing data maybe on hundreds of thousands of patients, but you never get a single patient record. People see that as an attractive way of coping with the fact that we don't today have a solution to the issues you two have been discussing, and that is the issues of consent, dynamic consent not yet being readily available, the lack of awareness of patients. So maybe you say, okay, we don't have to tell them because we're actually not accessing their real data. We're only accessing numbers of patients. I would like to ask you, Patrick, first of all, does that feel like an approach that would win trust? I mean, if a pharma company, for example, said, well, we want to examine, the extent of how many people are on which treatments for multiple sclerosis of a certain severity, and they wanted to run a few queries and get just numbers back, do you think that would be more acceptable?
So you think without names, without anything, just we need the numbers of the patients who are using that treatment?
Yeah, maybe the number of patients with more severe, less severe disease. So there may not be one number that comes back to the researcher. They may get a little table saying, well, if we take people with this severity of drug, there are five severity of the disease. There are 5 drugs. 83 are taking this drug, 16 are taking that drug, 27 are taking that drug, but you don't know who the 27 are. Do you think that would be more acceptable?
I think that is the problem, because I think they're doing that, and the hospital is sometimes stealing the informations, and that's without the how to say, without the permission from the patients. And I think because of that, maybe not maybe, but I think we build up the negativity about the pharma, especially in the countries like mine. You know, when you mention for some people with MS the negativity about that, them blaming the doctors or that, and I think again, just with a good education and said with the open information. So you don't need to share your name. Are you open to share that you're using that medication for a research like this and this? I think 90% will say yes. It's just a number that I'm using that, and if that can help us, I think it will be better. That's my.
But you have said, I think, that even though it's only numbers, you don't feel that it's comfortable for patients to just do it. They should still be asked.
I think I'm surely about that, because
I'm asking just for your opinion. Honestly, I'm not asking you to do more than just give your own personal feeling.
No, I think it will be much more better if it's just a one question to ask the patient, and the patient will say yes, of course, if I can help, and it will be much more easier.
Okay. So Petra, you're very familiar, I guess, with this architecture of federation. Kees has spoken about how the federated architectures do allow this safeguarding of the patient level data, how important it is that the data stays locally under the control of each hospital and only these numbers travel. But you're a data protection expert. Do you feel comfortable that this is a good way forward of protecting privacy in cases where it's not realistic to get consent?
I think it's one of the tools that will be useful as part of that building the framework. We will need to be careful where we use it. It works very well with data sets where there are a large number of patients. If we were to, for example, do queries on relating to people who've had the COVID vaccine, the numbers would be so large that there would be no risk to anybody's privacy. It becomes much more difficult when we're talking about rare diseases.
Yeah.
But I think there is another thing sitting behind that, and I hope this goes a little bit to what you were saying, Patrick. And it goes right back to what you were saying at the beginning, Deepak. It's the value. How do we share the value in allowing data to be used in that way? Because I think one of the things that can put patients off is that they don't see any value coming back towards them. And that doesn't necessarily mean them personally, but the patient community. And I think if we can do more to demonstrate that actually allowing that sort of federated architecture, query-driven research, how that can lead to better, faster, safer care, whatever it is we're trying to achieve, and we can demonstrate that value, we can help build the trust. And we have to use it for cases where it's appropriate. And there will be some cases where the patient population is so small that it's not appropriate.
Okay, that's very helpful. Patrick, your reaction to that? What's your feeling?
I totally agree, and I totally understand. And it's really nice to hear that you mentioned the value. Sometimes that people also want sometimes something personal, and I saw that. I can agree with that. And how to say it? I understand that's sometimes in a negativity way, But I think, again, with the education with that people, I think in a safer world of sharing data, and also with clear facts. So you're sharing this, and it's for this and this. I think it's just the clarity what we are missing right now when we are talking about sharing data, and why are some people so close about that.
That's really interesting. And I feel like if I had to have a personal take-home message from our conversation, just a personal one for me, it's really to say that you can't separate the ways that you protect the data and the way that you try to win trust in that from the value that trust brings. These two things are just, you can't separate them, because trust is kind of in exchange for value. I don't mean that people get paid. People feel that their data is doing good. They're willing to trust on the basis of good, rather than just saying, I trust regardless. And I feel that's a very powerful message I've really got from both of you. So thank you very much indeed for being part of this panel, and for sharing, along with Kees, the understanding of the federated architectures, which his organization is very involved in through the Eden Project. And let's hope that our patient community out there within the European Patients Forum feel enlightened by our conversation. And I look forward also, in case we get some nice questions through in the chat in a few moments. Thank you very much.
Thank you.
Thank you.
Good afternoon, everybody. It's amazing to have seen how much action and interaction there's been around this discussion. Clearly, the use of data is something that lies close to everyone's hearts. I'm delighted now to be able to ask some of the participants in this panel. Of course, I was one, but I'm going to now just moderate for a moment and ask the two other participants a little bit around the questions that you've been posting. And I'd like to begin actually by asking Patrick. We've had a question, particularly around how have attitudes changed recently, particularly the attitudes of young patients about how their data may be used. Did you have anything to add to that? What's your thought about how young patients feel about the use and reuse of their data?
Thank you, Petra, and hello. Thank you for the question. I think the question is really interesting and really good. To be honest, it's quite hard to answer on that question. But in general, I would say, as everything else, it's much more easier maybe to share the data in the last 2 years because of the COVID and the situation. Everything is digital, and I think that makes some research, some data sharing easier for the young people. And when I was talking with a local community, with the young patients with MS, I'm diagnosed with MS, and when I'm talking with the young people from my local society, I can say they really now more open for some actions, and they're also more open for data sharing when it's over, when you can do it online, because it's not taking so much time. I'm not talking only for the data from the hospital. I'm talking also about the data from the daily data, the data from the from every day. So I would say it changed maybe in a better way. I'm not sure, but I think it's in a better way. Thank you.
Thank you very much. And we see also a comment in the chat. Veronica Popper has said that she agrees with what you're saying and draws particular attention to the needs and particular issues of patients with rare diseases. And in fact, patients with rare diseases leads us to another very important issue, which is that question about anonymization. Is anonymization the best way to protect the privacy and the interests of individuals? Kees, you're you deal with this as part of the work that you do. And I wonder if you'd like to say a few things about the role that anonymization can play in making data more accessible for reuse and in how much it can solve some of the problems. Thank you, Kees.
Thank you, Petra. So, yeah, the question is if anonymization is really even possible. So, you know, a naive view would be, let's delete or obfuscate some of the critical identifying elements in data, such as names, obviously, but also birth dates, and maybe turn that into a birth year. And that is pretty much standard practice, I think, mostly with health data analysis, certainly analysis of, let's say, data that was generated for other purposes. The example of OMOP in Eden, that also includes these kind of so-called anonymization techniques. But the real question is, that was fairly soon after raised, and in the last few years, there's been quite a number of papers published on this. Is it possible, if I have this so-called anonymized data set, that I can still, using advanced techniques, reconstruct who it was? And of course, in rare diseases, this is quite possible. And the problem that you run into is that there is a balance in, you know, how much you delete or obfuscate in the data versus how useful it then still remains for analysis. I can strip out all the interesting identifiable parts, and maybe then what I'm left with is something that doesn't tell me anything, because, you know, if I don't know the actual age, or even looking at maybe seasonal effects in data, and I delete all that, then what I get out of my analysis doesn't tell me much either. So the real question is, what is how much do we accept? What kind of risk do we accept in a data set? And often, I mean, that's for every project different, but often there is a view that combined with some of the controls that you put anyway in terms of data governance and who you're sharing it with, that the risk that someone could potentially, using all the data and using advanced tool, reconstruct who it is, that risk is a risk that we are willing to take in order to get the benefit of the analysis that we can do with the data.
Thank you. That's really good, and it's good to give people that sense of the limits of anonymized data. In your answer just now, you used the word risk several times, and that just creates a link for me to say something about one of the other questions that arose in the chat earlier on, which was around security risks. And I think one of the things I'd quickly like to draw attention to is that although, of course, technical security is really important when we process and reuse data, plenty of studies have shown that actually the greatest risk to security of data is us, it's humans. It's how we as humans, whether that's as a clinician or as an administrative person within a healthcare research environment or health provision environment, or even us individually as patients, we pose a really significant risk to the security of data. So I'd actually like to say, while technical security is of utmost importance, we cannot and must never skimp on the training that we give to everybody we work with, and the training that we give even to patients around security of data, how you should keep your data and your information secure. I'd actually like to invite Deepak, who moderated the session before, to come back and share a few comments. And Deepak, unfortunately, I think your camera is frozen, but I do believe we can still hear you well.
Yes, I'm sorry about that, Petra.
No problem. I think we can hear you. So I'd just like to ask you to comment on some of the issues that were raised in the chat about the interests of commercial actors in the use and reuse of data, and how their interests could be addressed and how they could be matched with the interests of patients. Thank you, Deepak.
It's a really important point, and it comes up so often also in surveys. When people are asked, are you happy to share your data with, universities or with industry? People are much more nervous about industry. And the difficulty is that sharing data with a large company with 50,000 staff and maybe global offices feels like you're putting data into a massive space. But we need to think about what we give the data for. Quite a number of companies do vital research that gets translated into things like new drugs. The COVID vaccines that we're currently benefiting from were developed through investigations that use data. But when I've engaged with companies, what I find is they're very willing to be very strict about use. If you share data with a massive company, that doesn't mean the whole company gets the data. The teams that are working on a research question get the data. When the marketing department come and say, hey, I hear you've got some interesting data, they are not permitted to share it. They're not permitted to use it for any other purpose. And I think, I'm not saying that's right or wrong. I'm saying when we engage with the patients and the public about industry use, we need to help them to understand that they need to make decisions about whether they're happy for the data to be used by a company who's conducting scientific research to develop an innovation that is going to come back into the health system as a new drug, a new vaccine, a new device, a new algorithm, because actually that is beneficial. Now, there is a further challenge, which is if the company finds its development costs go down because they were able to use data that might otherwise have been hard to obtain. And so they got the product eventually to the end of the pipeline with less cost. How does that come back? Does the company say, we reduced the price of the product by a little bit because we saved a bit of money thanks to your data? That's really hard to quantify, but it's a really important question that we must not ignore. So my feeling is we have to have more debate, more discussion about how does the value to the company translate back to society in addition to the product. Thanks a lot, Petra.
Thank you, Deepak. Of course, with that, you've raised so many other questions, and we are down to just a few minutes. There was a whole stream that's opened up. Case, I'm going to ask you to say something very briefly about the role and value of standards and interoperability, knowing that this is several PhD theses in itself. Thank you, Case.
Yeah, it is. But I saw the question from Christoph, and I was discussing this recently in the Voice of Eden podcast with Danny Prieto from Oxford. And he's one of those people that run a lot of studies, including for the EMA, the European Medicines Agency, on safety of drugs and devices, etc. And his answer was that yes, there's a lot of work involved in standardization, but if you do an analysis over multiple data sources, you often have to do some type of standardization anyway. It's not like you can just take UK primary care data and a registry from Germany and just ask it the same question. So you have to do often on a study-by-study basis some data harmonization anyway. And then of course, if you map to a model, it may be a bit more effort, but it very quickly pays off once you run that second and third study. And you do tend to reuse data sources multiple times for multiple studies. So that would be my answer.
Thank you very much. Wow. Well, I think what we've demonstrated in this session is how huge the topic of data reuse is. Data is whatever image you want to use, whether it's the new fuel, the new oil, the lifeblood, it is what drives digitization of healthcare. I'd really like to thank my fellow panelists for your contributions. Deepak, I'd really like to thank you for having moderated us so excellently before. I wonder whether maybe I can just try and summarize in just the few seconds that we have left in saying that what we've really seen here is that data has a huge amount of challenges as well as a huge amount of opportunities. We see that it demands new types and new forms of legislative response. It demands new technical responses, and Case has given us a great example of that, which necessarily demands issues around standardization and interoperability. But absolutely central to it all is making sure that patients, whether they're like Patrick or like any one of us, can really appreciate what is being done with their data, why it's being done, and that we can return the benefits that arise from data use to patients in everyday care. And on that note, I'd like to thank everybody and wish you all best for the remaining days of the conference. Thank you very much indeed, and goodbye.